Now we're going to talk about the protease inhibitor in HIV treatment. The protease inhibitor, first, what is the protease in the HIV? We have a aspartate, well, the HIV has the aspartate protease. This enzyme actually has two proteins in each virion particle. The protease at the end of the introduction of proteins made by our cells. The proteins of the HIV are joined, they appear together after the ribosome synthesize all this, and the protease what does is coats the proteins. And so this is the maturation phase of the virion particle. So the maturation is made by the protease. So if we inhibit the protease, then these proteins are going to be stuck together and there is no maturation of the virion, and this is very, very important in the treatment of HIV patients. Now the inhibition is made by, we have a lot of names. We're not talking about the commercial names, just the scientific names that end in something navir. So we have darunavir, indinavir, ritonavir, lopinavir, what else? Saquinavir, fosafrenavir, etc. Now this works just by inhibiting this protease. Now the most important is how we're going to use it. In other video we have the treatment of HIV, the other treatments, but we give two nucleoside analog that inhibit the RNA or the DNA polymerase, dependent on DNA or dependent on RNA. Two of those plus one protease inhibitor or plus one non-nucleoside analog or plus one integrase inhibitor. So we need to give two nucleoside analogs plus one protease inhibitor. You cannot give just this. Next, the adverse effects are lipodystrophy. This is the moving of the fat especially in the face and in the abdomen. Looks like Cushing syndrome, but is not because of excess corticosteroid like that. Some drugs produce more lipodystrophy than others, and the same way also increases glucose. So we have glucose abnormalities like hyperglycemia. Also thrombocytopenia. So this could lead maybe to bleeding, and nephropathy. Could be nephropathy, meaning specifically nephrolithiasis or crystalluria. In crystalluria we have some crystals and could produce the kidney damage or acute kidney failure, and it's because of the crystals that are deposited there, and this is a post-renal acute failure. In post-renal failure we have at the beginning the bone creatinine ratio is elevated. Specifically the one that produces this crystalluria is indinavir. Next, the interaction with the CYP, the cytochrome P450 of this enzyme. We have that ritonavir inhibits the isoform 3A4 and the isoform 2D6. Also activates or potentiates the action of the 1A2 isoform, but if you wish, only remember this, because ritonavir we think it as is a inhibitor of the CYP 450 enzyme. Next, the the rifampin also interacts with the CYP. This induces the CYP 450, and so because protease inhibitors also interact with this CYP 450, so if we give rifampin, then we are altering. Let's say that this HIV patient also has tuberculosis, so we are giving rifampin. So in this case, it's better to give rifabutin because rifabutin do not interact with the CYP 450 as opposed to rifampin that activates the 450